Hello, good evening, and welcome to today's edition of The Couch. Today is the 30th of May, dying embers of the month. May is my favorite month for very obvious reasons. I'm sad to see May go, but June is coming. June is coming with all of its promise, and we are excited, about all the possibilities. Tonight on the show, because it's a lifestyle edition of the show, Tuesdays are for lifestyle, social issues. So because it's a lifestyle edition of the show, we thought to have some education, to create some awareness. It was something that we hear about a lot, but I dare say we know absolutely nothing about, myself included. Tonight, our conversation is on hypertension. Hypertension. How much do you know about hypertension? Do you know the role your lifestyle plays in you preventing hypertension, in you treating hypertension? How much do you know about that? How much do you know about the drugs, the effects it has on you? Most importantly, what are the myths about hypertension? What are the facts? What are the truths? All of these things. Great conversation this evening. I entreat you to get your bottle of water as we relax on the couch, and you relax on the couch, and we have a lovely, good evening. Stay with us. We'll be right back. Welcome back to The Couch with Maame Ama Pratt. Tonight, we are in conversation with learned people. You see, learned, let me mention their names. So I have in the studio with me Dr. Shirley Wiafe. She's a physician specialist and cardiology fellow in training. Hello, Doc.
Hi, Emma.
Lovely to meet you.
Lovely to meet you.
Very lovely to meet you. We have Dr. Kofi Asamoah. He's physician specialist and cardiology fellow in training. Welcome, sir.
Thank you very much.
Very lovely to meet you both.
Same.
Very lovely to meet you. See, we call some other people learned, but you are the real learned people. You know that, right? The things you people know, and Charlie, let's start from the myths. Actually, no, let's start from hypertension itself. What is it? Because everybody has said hypertension, but what is it?
Okay. So, basically speaking, hypertension is just elevated blood pressures. So, there's when you take a blood pressure reading, we have a systolic and a diastolic. So, the upper arm, which is the numerator, is a systolic, and that's the force with which your heart contracts. And then the lower part is the diastolic reading, which is usually lower than the upper one. And that is when the heart relaxes in between beats, the pressure that is generated. So there's a normal blood pressure. So ideally, a normal blood pressure should be anything below 120/80. Okay, when you are that's for the systolic, the upper reading. So when it's optimal, you should be below 120/80. That is the ideal. Between 120 to 129 for the upper part, it is normal. High normal is 130 to 139 for the systolic. So anything above 140/90 is considered hypertension. So that is, so ideally we should be below 120/80. That's the optimal reading. But when you are 140/90 and above, then that is the beginning of hypertension.
Wahala.
Yes, and you can only say for a fact after you've had a blood pressure reading with a SFIG. You will not know you have it until it is objectively assessed by measuring your blood pressure with a SFIG.
So it is absolutely possible to be going about your normal life, going up and down every day, eating, sleeping, going to work, living with it, and not have a clue.
Being clueless.
Yes, it's very possible. I've actually seen a patient like that. This was about 8 years ago. He was on his way to his wedding when he collapsed, and then he was brought into the hospital. He had a stroke. Blood pressure was through the roof, 240 over, was it 120 or so. So clearly, to get to this point, he had had hypertension for so long, but it hadn't been picked up, except for his wedding day. And at that point, he had had a stroke. So it's very possible to go through your day-to-day activities with no limitation at all, but your blood pressure could be high.
Surely there are symptoms.
Unfortunately, hypertension doesn't have symptoms. Sometimes you may be lucky, it may give you a few headaches, but then on the whole, it doesn't have symptoms. The symptoms that you would experience are symptoms of the complications when they start to set in. That's the issue with hypertension.
What should we do? I mean, this is this is scary stuff. You have no idea how you're scaring me right now. This is scary stuff. No. You have achieved it.
You don't mean to scare you.
No. What should we do? What should we do? Because you're saying headaches are very normal.
Yes.
The whole of last week I had headaches every day.
See?
Right?
Yeah.
So what should we do?
Exactly. That is why we as a society and globally, the month of May has been set up.
Right.
To commemorate hypertension, for us to educate the populace, to engage in advocacy, screening programs, to let the average Ghanaian know about hypertension and the havoc it can wreak on lives and on families. So, in terms of what is to be done, blood pressure checks are very important. But then the thing is, we don't look at hypertension as an isolated entity. Hypertension comes with a gamut of other cardiovascular disease conditions. So they kind of tend to aggregate together.
They move together. Trouble.
So
they come in pairs and
so,
they reign.
Exactly. So they tend to aggregate together with bad sugars or high sugars, bad cholesterols, and some other conditions which increase your risk of developing the complications that we so dread. So like what he mentioned. So what needs to be done? We need to educate, okay? But then at the end of the day, you as a person must take responsibility for your own health. Our lives as they are now are very stressful. We need to manage stress. There are modifiable and non-modifiable risk factors which increase one's chances of developing hypertension. The modifiable ones are the ones you can do something about. So let's say if my lifestyle is very sedentary, I'm always driving from location A to location B. I hardly go for walks. I hardly exercise. I'm eating a lot of junk food. Okay? I'm smoking. I'm drinking alcohol excessively. I'm taking illicit drugs. People are on amphetamines, people are using cocaine, a lot of recreational drugs. I'm not managing stress. All these factors are factors that I can do something about. I'm not keeping an optimal weight, an ideal weight. So once the lifestyle, the things that you have control over, when you are able to do what it takes to bring that control to bear, then it would also reduce your risk in a way. Right. Then there are factors you cannot do anything about. So those ones are mainly, we call them non-modifiable risk factors. Just by reason of the fact that you are black, just by reason of the fact that you are Asian, just by reason of the fact that...
Let's define Asian. Let's define Asian. What do we mean by Asian?
Okay. Well,
from where to where? Not to cut you, but just to take some information and go along.
So strictly speaking, we consider age over 55 as
we are not Asian.
But nowadays, it's starting to occur at even younger ages.
Don't do that.
Yeah. So even though by strict definition we work with 55, I'm not sure if we hold fast to it now, because things are happening at much younger ages now.
So it's dropped?
Yes.
Everything else. Everything else has dropped?
Yes.
It has.
This one too?
Yes.
Yes.
It has, unfortunately.
Please go on. So 1, regular checks. 2, lifestyle. Yes. And I picked a few things. Smoking, drinking, not managing stress.
Not exercising.
Not keeping an ideal weight.
Yes. And then
doesn't matter whether it's too skinny or too fat, right? Both are not good. Or the fat is the problem.
So when you are more like the fat is
towards the side of
towards the side of obesity, it's more of a problem.
So like me, it's okay.
It's okay. I'm sure you're okay. I'm sure your BMI is ideal.
Right. Please give us more information.
And so for the For the non-modifiable ones, we mentioned aging, we mentioned genetics.
Right.
So for some people, there's a family history of hypertension. You may have your dad, your mom being hypertensive. And so for you, chances are, the risk is so high because you are getting it the risk is coming from both arms of the family. So hypertension in the first degree relation is also a risk factor for developing hypertension in the successive generation. So that is something that you cannot do much about. But even with that, even though you have that high risk, if you work on the modifiables, it may delay how quickly you develop hypertension over time. And then, is there anything I've left out with the
no, I think in terms of the risk, the non-modifiable risk factors, I think that's pretty much it.
Yes.
Yes, as you said, there isn't really anything you can do about them. So we don't really focus too much on them when we are trying to advocate for things. We look more at the modifiable risk factors. Yes.
But I think that it's helpful if you know that once it's in my bloodline,
yes,
I should be a little more careful.
Definitely.
Right.
Definitely.
So I mean, all in line with creating awareness.
Yes, definitely.
Okay. So, I mean, talk us through the process of just walking into a hospital and trying to get your blood,
the blood pressure check.
Your blood pressure check.
Yes, so actually, now a whole lot of pharmacies also have it.
Oh, okay.
So you don't necessarily need to go to a hospital. You can go to a neighborhood pharmacy. And again, we have a lot of automated machines that you can purchase and own for yourself. So then you just get it, you have it in the house, and you check from time to time. What we are advocating for is that you do it at least once a year, which is why May is dedicated to measurement month, May measurement month. So you check your blood pressures. But the more you are able to check it, the better. What matters is that you get to the place you're checking it, whether hospital, pharmacy, sit, feet planted on the ground, not crossed. Yes.
Like this.
Yes.
Like that.
Ideally, quiet environment, no talking on the phone. The one measuring is not talking. You haven't had a cup of coffee or tea within about 30 minutes prior to checking. Because these are all things that could
Stimulate.
Yes, could increase your blood pressure at that time.
Right.
And then you check, usually we discard the first reading, and you check another 2 times, 5 minutes apart, and then you average them. This is best practice for checking blood pressures. But you and I know that in the hospitals the numbers are so large.
Nobody has your time.
Yes, so then usually what is likely to happen is they do the first reading. If it's normal, they leave you alone. If it's high, then they ask you to rest, and then it's checked again. Yes, but then really you should be able to check at any neighborhood pharmacy, clinic, hospital, and then if you're able to get the machine for yourself, you check. One reason why we advocate for that is we have a phenomenon called white coat hypertension, where being in the hospital setting, seeing a doctor, seeing a nurse, sort of gives you some anxiety and makes your blood pressure spike. So there are people who come to hospital and every day you check their blood pressures is high. You ask them to monitor in the house and every day it's normal. So that's white coat hypertension. So if you have the machine yourself, then you check in the house and then this white coat effect is eliminated. Then we know what your true blood pressure readings are.
Right.
Yes.
All sounds wonderful. I want us to debunk a few of the myths we have, and then we can look at proper education. We have some slides. Yeah,
Sure.
Today it's I'm all for it. I'm ready. I'm in the classroom with my pen and my paper. So let's start from some of the myths. What are the myths? What are the truths?
So well, one is that if you start taking blood pressure medication, then because you started taking the medication, you are hooked to it for life. You are not hooked to it because you are taking the medication. It's because your blood pressures are high. And so you start taking it, blood pressure starts to come down. Don't stop on your own. Yes, there are some people that on medication, their blood pressures come low to the point that we are actually able to discontinue and then observe at regular intervals. If it starts going up again, we restart. But that wouldn't be classified as a cure. Hypertension is not cured. It is basically what happens is the arteries stiffen up. Okay, well, before that, there are two types. You have primary and secondary. Primary accounts for about 95% of hypertension cases. And this occurs just because. So as part of aging and lifestyle and all, the artery starts to stiffen. So then they are not able to relax and contract based on your activity to make your blood pressure fluctuate between high and low. So it's usually generally high. These people are likely to be on medication for an unspecified duration of time because the medication is needed to help control the blood pressures. Then we have secondary hypertension. This occurs, so this is the commonest type that occurs in kids, but then in adults about 5%. This occurs because you have another condition. So for example, yes, there's a kidney disease, and as part of the kidney disease, you're manifesting hypertension. As part of thyroid disease, you're manifesting hypertension. If you treat the underlying disease, then the hypertension is likely to resolve.
Right.
Pregnancy is another one.
Yes.
So pregnancy, BPs go up, and some people, they deliver pregnant and then the blood pressures resolve. Unfortunately, a few would persist and then transition into full-blown hypertension and will need treatment for that. So then myth number one is that it's cured, hypertension is cured. That isn't, and it's something that we need to have in our minds.
Okay.
So once you get it, that's it. What? There's no cure. It's just managing.
Yes, we manage
for the rest of your life. You're managing
For the most part. Yes.
So there are people who have managed hypertension for 40 years, and they're perfectly fine. They are functioning perfectly in society. There are people who are diagnosed in their 40s who are 85, 90. They still come to clinic for review. They're just coming because it's their review date.
Exactly.
No complaint. Oh, doctor said I should come, so I've come. There are people like that.
My dad is an example.
Wow.
My dad is past 70. He's been on his antihypertensive for over 30 years.
He's fine.
Fine. Very, very fine.
Right.
Yes.
Right. But it's. I don't want us to stay here too long. But it's a real thing, and I feel that we're about generally most things. Right. I feel as though as soon as you start, I mean, even for general multivitamins, once you want to stop, you feel deficient in a way. I don't know if I'm making, especially for very high performing people. I'll put myself in that category. You're always active, you're always running around. Sometimes you feel, oh, let me get a little help, because my own system is failing me every now and then. But once you start, if you do not take these medications for maybe 2 or 3 days, you tend to feel very down. So then in my mind, I'm getting addicted. I need to stop and figure out a way to let my body deal with my body. I don't know. So I can understand the reasoning behind why somebody would think, oh, once I start taking pressure medicines, I'm hooked for life, like I'm addicted, or, I can understand that. It's just a lame mind talking, isn't it? The science doesn't back it. Is that what you're saying? Is that what you're saying?
Yes. So the science doesn't back it.
It doesn't support.
No.
Yes, because if you discontinue, then now what was bringing your pressures down is gone. So your pressures go up, and they stay up persistently, and then put you at risk of various complications. But then if you're on the medications, then the medications are giving you the control that you need. In the event where you think you may be experiencing certain side effects or whatever, you return to your doctor. Doc, this is what's happening to me. So can we have a look at is it from the medication? If yes, what can we do about it?
Exactly.
But don't take matters into your own hands and say, okay, this is happening. I'm certain it's from the medication. I'm done. Because the next thing that happens, in a few years, you'll be rushed into the emergency unit with something else.
So it's about you doing a risk-benefit analysis. So the risk of not being on your medication, as opposed to having to live with that little inconvenience of taking your medication every day and surviving, being there for your family. Exactly. Being there for your family. Because we've had strokes in 45-year-olds. There was a young gentleman I saw, very fit-looking young man on the outside. He was actually a bouncer at a nightclub. So you can imagine the physique. And this man suddenly goes down with a stroke, and his young wife now has to leave work and take care of him. And unfortunately for him, his was quite dense, so he was bedridden. I mean, that is not the kind of life you wish for yourself or for your family.
At 45.
At 45, not at all. You wouldn't want that. So it's about balancing the two and then deciding what's more important. Because certainly taking your medication and keeping your blood pressures under control, I mean, would serve more of a benefit to you and your family than going off them.
Absolutely.
That is certainly not the way to go.
Absolutely. Okay. So that's myth number 1. If we could do about 3 myths.
So myth number
awesome.
2, I think I would like to talk about one of the main reasons why a lot of the male population tend to go off their antihypertensive.
It sounds interesting already.
Yeah, so it's a phenomenon with the males. We don't tend to have that with the females. So a lot of them come in, they come through the clinic, and you realize that, you were managing them, they were doing well on their medication. And at some point in time, they come in, blood pressures are poorly controlled, only for you to find out that they've stopped taking their medication because they're experiencing some erectile dysfunction or sorts. And the thing is, the very pathophysiology of hypertension, the disease process itself, actually facilitates the development of erectile dysfunction.
Let's understand the dysfunction. What's happening?
So they get sexually weak in bed.
Oh, weak.
Yes.
I thought it was hyper.
So either they are no.
Okay.
No, so it's more of a downside.
Right.
To
Nobody likes the downside.
Not at all. To their sexual function. So then it becomes one of the major reasons why a lot of men tend to go off their antihypertensives. But then the very disease process itself engineers that. So diabetics, hypertensives, by the very nature of the way the disease process damages the lining of the blood vessels and the narrowing Dr. Asamoah mentioned, it all reduces flow, to affected organs, and then they don't function as well. So you don't stop your medication because you've noticed that your sexual prowess have taken a downturn.
So medication or no medication, you will have a downside.
You will have it because you have hypertension.
Right.
Diabetes also does that. So once you start experiencing those symptoms, it's good to get back to your doctor. And then you can have a discussion. If there's a contributory factor from the medication you are on, I mean, we know what to do. There are other classes of medication we can prescribe for you to counteract that effect. Or we may give you medication to boost your performance in that area. But then it's always a bad idea to just stop taking your medication because you've noticed that in that area, some deficiencies are beginning to emerge. Yes.
I mean, the hospital is truly your friend. The doctor said nobody wants to, down anything.
Not
at all. At all. Okay. Third one.
Yes. Third one is that a lot of people believe hypertension is a disease, 1, of the old, and 2, of the obese. But there are people who are slim and are hypertensive. There are people who are young and are hypertensive, not from a secondary cause, but just because the family history is so strong. So family history is so strong, and then there are also some of the modifiable risk factors. Let's take an average person who, for example, stays in, let's say, Kaswa, and the person works, say, airport. Wake up by 4 o'clock, out of home by 5, get to work at airport, let's say, around 7:30. Because of how early you left, you couldn't get any good breakfast. You buy a fizzy drink and a pastry, high in carbs, processed food. Start working, you have deadlines. Sometimes you may even miss lunch. If you get to go for lunch though, you're getting some fast food. You have no idea how much salt is in it. They've added salt, they've used bouillon cubes, a lot of MSG in it. Back to meeting your deadlines. You close at 5, but because of traffic, you decide, okay, I'm going to stay till about 8 o'clock and work extra. Then you leave, probably get back to Kaswa at 10. You've not had dinner, you're hungry, so you will eat.
A bit of kinky.
Yes. Yes, maybe 2 balls of kenke because it was a hectic day. Yes. Then you eat within 30 minutes, you're asleep. You didn't burn the energy that you used. 4 o'clock, you're awake. Cycle continues.
But this is our life.
Yes, unfortunately.
This is our life. As you're speaking, I'm just looking at you like,
Yes.
there's nothing you're saying that is, this is our life.
Unfortunately, it is. Yes, and all this is predisposing. So then it's something that we really need on a broader scale to look at. Are there ways that we can modify our workplaces to make things much more conducive? I think things got a bit better when the working from home aspect came into the picture with COVID and Zoom and everything. But that also started to encourage a sedentary lifestyle. Because now I'm sitting behind the laptop, I go to the fridge, get a drink, get something, I'm back behind the laptop. I get up, back behind the laptop. So then that's also, it looks like whichever way we go, it has its vices. But again, there are slim people who have hypertension. It's not just those who are fat. So then everyone needs to check. Everyone needs to know their numbers, just so that you know where you stand, regardless of your physique, regardless of your schedule, whether busy or relaxed. Especially if busy, you need to check.
Absolutely. Ooh, this one is close to home. Okay. Is there anyone you'd want to touch on, or can we proceed? Is there any other myth that you think is very important that you at least speak on? I mean, today we want to create as much as awareness as we can. Is there any other myth you want to?
I think basically
we've covered.
Yes.
So can we go to the classroom now?
Yes.
So MCI, if you are ready, let's have the first slide so we can have a bit of education. Okay, so there we go. This one.
Yes. So I'll talk about this. So hypertension affects various organs. So as you can see over there, from my left to right, there's the heart, the eye, the blood vessels, the kidneys, and then the brain. So looking at the heart, as Dr. Wiafe mentioned earlier, because of the high blood pressure, it sort of damages the lining of the arteries, and then you can have cholesterol deposits in there. That's a process that we call atherosclerosis. Now when this happens, it narrows the path along which the blood flows. So then parts of the heart start to get starved. When you start to get starved, you and I, we start to have tummy aches because we're hungry. So when your heart starts to get starved, you start to have some chest pain. Usually worse when you're active, because at that time the heart needs a bit more, but then when you relax, it gets better. And then this is a precursor to developing a heart attack later on. Now, aside that, again, the blood pressure refers to the pressure against which the heart is pumping. Now let's liken it to a young man who's gone to the gym, is lifting metals. So then the young man starts, it's so difficult. He uses so much effort, starts to have pain, eventually he overcomes it. Then he feels, okay, this is easy, let's move to the next weight. And the cycle goes on. When your heart is pumping against the high pressure, the heart struggles. So then it starts to bulk up so that it can meet that pressure. But when it bulks up, its blood supply doesn't increase. And it bulks up at the expense of the ability to relax to receive blood, because now it's so well toned. So when this happens, then over time, you start to get breathless with minimal activity, and if you don't get it controlled, the activity becomes more and more minimal. So then people will tell you that from here to the junction, I start to pant, I have to rest. Now because of that as well, fluid tends to build up within the lungs, and then it can give you breathlessness, usually worse when you lie flat, but better when you sit up. So some would tell you when they are sleeping, they wake up gasping for breath, because the lungs are filled with fluid, it's not getting enough oxygen in, and this is what we call heart failure. So this is how hypertension affects the heart.
Right.
For the eyes as well, there are tiny arteries within the eye, and what happens is that the high blood pressure can cause these tiny arteries to burst, and then that can result in what we call retinopathy. It goes through a number of stages. So early on, it may not be picked up. And if you're not careful, at the time it's picked up, that's when you have significant blurring of your vision and or, unfortunately, blindness. So it's also something that we need to take note of. The vascular dysfunction was explained by the atherosclerosis, and I'll let Dr. Wiafe explain the kidney and the brain.
Yes, we have quite a number of them to go through, so Doc, if we could rush through them. So we have the renal damage now.
Yes.
Okay, so with the renal bit, most of the time, hypertension. So it can go two ways. You can actually have hypertension as a manifestation of long-standing kidney disease, or you can have hypertension causing kidney disease. So hypertension can affect the vessels supplying the kidneys. You could also have some special types of hypertension, the secondary hypertension Dr. Asamoah mentioned, affecting vessels and causing a narrowing, which over time can also damage the kidneys, make the kidneys stiff, small and shrunken over time, and then the kidneys are not able to do what they are supposed to. The same atherosclerotic processes that he mentioned, the vessels are everywhere. So these vessels are supplying vital organs everywhere, in the kidney, in the brain, in the heart, everywhere. So it's a diffuse systemic process. So over time, the kidney's function declines, and then a patient may require renal replacement therapy, i.e. dialysis. That's why we have a lot of young people these days, people with hypertension, diabetes, over the long term who were not well controlled, developing renal failure or kidney failure, requiring that they be on lifelong dialysis, or the other way to ameliorate it is to have a kidney transplant, either from a live donor or a cadaveric kidney. And we know kidney disease is on the rise in Ghana today, all as a result of hypertension.
The next one is the stroke, dementia, hemorrhage, Alzheimer's. Okay.
So strokes are of two types. They could either be ischemic or hemorrhagic. When we say ischemic, it means that the same atherosclerotic process that we said, that brings about narrowing of blood vessels. Over time, as hypertension is uncontrolled, as you have other risk factors aggregating, bad cholesterols, bad sugars, plus some other factors coming into play, the blood vessels stiffen up, they narrow, and then at some critical points, you can have the plaques within them, which are the areas of narrowing, undergoing rupture and then occlusion. So once you have a clot obstructing an already narrow lumen, then it means that blood supply distal to that portion of the brain is cut off, and then you lose function on that side of the brain. And sometimes it may actually burst, and then you have a hemorrhagic stroke, and then blood pooling or encasing in this rigid skull, which cannot expand to contain the rapidly accumulating blood. So those are the two mechanisms of strokes that hypertension can bring about. It can either be a clot in the brain, blocking supply to the portion of the brain distal to where the clot is, or it could actually rupture, and then blood supply is also compromised, and then you have pooling of blood. The rate at which blood pools will determine how catastrophic the consequences will be, and how rapidly your symptoms will progress. And then hypertension can also cause dementia. So sometimes people can develop little strokes, which may not be overt, which may not manifest as a marked weakness. So we have this same process occurring in the smaller vessels in the brain. So we call them lacunar infarcts. So when you have all these tiny infarcts occurring over time, as you continue to lose brain function from these strokes, over time, mental capacity can be affected. And it tends to manifest in people as they get older. They may not have had a full-blown stroke with marked weakness on one side, but then sometimes when you scan the brain, you can see evidence of strokes involving the smaller vessels of the brain, which then manifest as dementia in the long term.
In your older years. Wow. I wish MCR could just flash the images, and I hope that we can make time to come back and go over every single one you know, of these images and what you have. So there's this one that looks at, it's very interesting. If you want to talk us through this one quickly.
Yes, so with this one, what's happened is that because of the high pressure, the smaller arteries tend to become a bit weaker, and then they can burst if you don't control the pressure and cause the brain bleed. So that's the hemorrhage for the stroke.
For the stroke.
This is
right. And this one, that's what we were talking about earlier.
Yes.
Right.
Yes. So
this is the, you know, the third slide.
Yes. So that shows both the atherosclerosis and the bleed.
Right.
So the first one shows the atherosclerosis. You can see that the vessel is narrowed. So then there's very little blood going through. Right. Then the second one is the bleed.
Right. And this one. Oof. This one.
Yes. So that's what we call an echocardiogram. It's a picture of the heart, a scan of the heart, more or less. On the right, so
it's
this
like
is
a
the
scan
same
of your womb.
So this is the same heart, pretty much. So you realize that the portions marked A and B on the left are thicker than the corresponding part on the right. And that's because of the high blood pressure. So as I said, the heart bulks up as it beats against the pressure. And this is a precursor to having heart failure, then developing heart attacks, as I explained earlier on.
Okay, the fifth one looks at the heart attack itself. It's the blockage of arteries, I think.
Yes, exactly. So there's a blockage, and he's clutching his chest in pain.
Oh dear.
Because the heart is getting starved.
Right. That's the fifth slide.
Yes.
Okay. This one. Okay. Yes. Okay. And then the next one. Oh, this is a heart. I know this one. I remember this one from science.
Yeah.
So that actually shows the heart attack. So you see the insert over the circled yellow. You see where the narrowing is, and there's a clot that has blocked it.
Right.
So now in the bigger image, the gray part is the part of the heart that is dead. So that part is no longer functioning. So the rest of the heart is beating, but that side does not contribute to the heart beating. And that in itself puts you at risk of a number of complications, rhythm abnormalities, physical limitations because the overall output of the heart is reduced, etc.
Wow. And this one, this feet, interesting.
Yes. So again, atherosclerosis, reduced blood flow to the legs. So then the leg starts to die. Now the part that is black is gone. It's gone. It can't be saved. All right. The part that's brownish, maybe a bit purplish.
About to die?
Yes.
Oh dear.
Unless you intervene.
Okay.
So then there are interventions to help open it up and then restore blood flow so that that part comes back to full life. But the black part is gone and it will have to be amputated. The black part will have to be amputated because it serves as a nidus for infection and can lead to issues.
Right. And this one, stages of chronic kidney disease.
Yes. So Dr. Wiafe explained how the kidneys get involved. So you realize a nice, healthy, juicy kidney on the far left.
Ooh, very juicy.
And then as it goes to the far right, it starts to shrivel. Yes. So at that point, you are end-stage kidney disease. So the person will probably not be peeing. The person will start to swell up with fluid. And I'm sure the next slide would talk about dialysis.
Yeah, so let's go to the next slide.
Yes.
This one.
Yes.
So that is dialysis. That is the treatment for end-stage kidney disease. Now at this point, the machine is doing the work of your kidney for life, unless you get a kidney transplant. This would cost you about 450 cedis a session. You need at least 3 sessions a week. So I'm talking of 1,350 cedis a week. So in a month, that's times 4 for the rest of your life. So question is, what work are you going to do? You're going to end up depending on others who are probably paying kids' school fees, feeding their families, and yet they have to dedicate 1,350 cedis to you every week for dialysis.
That's a lot.
A whole lot.
That's a lot. Let's look at the last slide and then.
Yes, so this one is for the woman. So this shows blood flow to the placenta, which feeds the baby with blood when the baby is in the womb. So at the top, you realize that the size of the pink part is wider. But then when you come down, because of hypertension, it's narrower. So there's reduced blood flow to the baby. So then that can contribute to having what we call intrauterine fetal growth restriction. So you have a baby that's very small, the organs are not so well developed, the organs are small. sometimes even with this, it can cause part of the placenta to die, the way you have a stroke or a heart attack. And if you have a certain critical mass dying, then the placenta can just detach from the womb. Baby loses.
That's the end of the baby.
Yes, unless it's picked up and baby is brought out immediately.
Wow. Wow.
Yes.
Wow.
So hypertension affects pretty much everything, and that's why it's a big deal.
Everything, your eyes, your kidneys, your heart, your brain, your feet,
Yes.
everything. The formation of the baby in the womb, everything.
If it has to do with the body, hypertension can affect it.
My goodness. You know my biggest take home from this conversation? Move.
Exactly.
That's my biggest take home from this conversation. That's all. So now that's my mantra. Move. So try and have a walk in the morning. Perhaps try and have a walk in the evening. In the office, maybe get up and go for lunch instead of sit down and have the food brought in. I'm thinking.
Yes.
I'm thinking.
Yes.
There's so much more we can do.
Yes.
There's a whole lot more.
There's a whole lot more.
And we hope that this would be the beginning of a much more conscious, I don't know if I should say national lifestyle. Yes, because yes, we start by talking to pockets of people, but we need a national conversation too, because it's one of the leading causes of mortality and morbidity across the globe. And numbers are rising in low middle income countries. So then we need to have a national conversation about this. If we believe human resource is key to development, then we need to have this conversation to preserve this human resource so we can develop. Otherwise, we're not getting anywhere.
We're in trouble. Yeah. Final words, and you're out. Final words.
All right. So hypertension is a silent killer. Okay, but hypertension is treatable or manageable. Okay, you can live with hypertension for the rest of your life, provided you liaise with your healthcare provider. You are doing everything we expect of you. You are managing what is within your remit to manage. You are taking your medications as you should. You are keeping your visits with your clinician regularly. And I think the issue of refills are also very important. Sometimes in between clinic visits, patients run out of medication, and sometimes they wait till the next visit to get a refill. So in between visits, let's say if you are scheduled to see us in 3 months, and in 2.5 months your medication runs out, nothing stops you from refilling for those two weeks to prevent any catastrophic event from happening within that time frame. So stay on your meds and you'll be fine. You'll live a healthy, normal life. And you'll be there for your family, you'll be there for the nation, and you will live a full and healthy, happy life.
Thank you. Thank you so much. Thank you so much for this education. Thank you for the work that you are doing. We are grateful. I hope that we'll come back and expand on this conversation sometime.
If we're needed, we can always.
Absolutely, of course you are needed. I see your t-shirt says World Hypertension Day.
Yes.
Thank you so much for coming. So this has been our session with Dr. Shirley Wiafe, a physician specialist and cardiology fellow in training, Dr. Kofi Asamoah, physician specialist and cardiology fellow in training. We've been doing some hypertension awareness. Thank you so much. Don't go nowhere. The conversation continues. Welcome back to the show. Welcome back to the show. It's the month of May, and all great, marvelous, wonderful, awesome things happen in May. May is the best month of the year, hands down, right? So, I mean, from last week, we've been having all those conversations that are necessary. So we had World Menstrual Hygiene Day. It's in May. What else? So many initiatives. I've forgotten some of them, but yeah, you get the picture. Today we've had World Hypertension Day, May. On to the next one, and this one is about skin cancer awareness, also happening in the month of May. Awesome, wonderful things. Our conversation is with Dee Dalasi. Dalasi she's an artist, she's a humanitarian, she's an entrepreneur. right? But what I love most, and I read it about Delassie, and I'll say this, is that she is the diva with skin kissed by the sun. I'll say that again. The diva with skin kissed by the sun. How many of us can say this? How many of us can say this? Welcome, Boo.
Thank you for having me.
Oh my goodness, look at you.
This is really a full circle moment.
Right.
Because when I first moved to Ghana, a little over 4 years ago, I came to Pan-African TV, and this was the first major television spot in Ghana that I had. And now 4 years later, I'm back.
Of course you are. That deserves a drum roll. Like that needs a drum roll.
Yes.
Welcome back. Looking
you.
just as fabulous.
Thank you.
You know, you just look like the skin, the sun did more wonders with
Yes,
you.
amen.
And of course, Obasuma as well.
Yes.
In
yes.
2019
Yes.
for our social conversation.
Yes, and that was amazing.
I know. You're actually the first person to speak.
Is
No,
it?
the second.
Yes, yes.
That was Rita with confidence, and
Yes.
you came with skin.
Yes.
Skin
yes.
bleaching.
Yes.
And listen, that's a very relevant conversation
Yes, it is.
till the day. But let's talk about that.
Yes.
Why is this conversation important? Why do we need a whole month to talk skin awareness?
Right. Well, this month is Skin Cancer Awareness. It was started in 1984 by a coalition on skin cancer in the United States. And over the last almost 40 years, it's picked up steam, and globally now it's become recognized as an official, I guess, month theme in terms of healthcare. The reason why it's so important, at least to me personally, is because we've always been taught that skin cancer is a white man's disease. Because we have melanin and we can be in the sun without skin burn, without skin irritation, without heat allergies and things of that nature, because of our very protective melanin, we have been socialized to believe that that's enough. And you know, for years it was. But now, in the year 2023, after all these years of industrialization and so much pollution, we have deteriorated the ozone layer. So maybe 100 years ago, whereas we wouldn't have to worry about being in the sun and its effects, now, because of all of this air pollution and the deterioration, now we're getting more UV rays hitting our skin that we didn't used to. And our melanin alone isn't quite enough. So that is one issue. Then another issue is skin bleaching. You know, skin bleaching is very pervasive. It's something that happens on every corner of the globe, anywhere where there's indigenous people, from India to Brazil to the Caribbean to here in Africa, people have been bleaching. And I think largely that's attributed to colonialism and imperialism. When the European decided to go on this globalization mission to kind of take over the world in a sense through violence, through religion and other means, what came with that was their beauty standards. And once you have beauty standards and you bring that or enforce that onto an indigenous community that does not fit those standards, you have people doing things and trying to contort themselves to fit into that standard. And it's unfortunate because people believe if you have lighter skin, you know, you're more attractive.
Yeah.
You're more honest, you're more kind, you're more intelligent.
That's softer.
Softer, right?
More bougie.
Yes, exactly. All of these things. And it's absolutely not true. I mean, it doesn't have any merit at all. But if you repeat something long enough for enough people, you can definitely get a reaction. And that's what we're dealing with today.
Absolutely.
So
I wanted to go to the statistics, and you provide these statistics. You say according to World Health Organization, 40% of African women bleach their skin. In some countries, the figure is higher. A staggering 77% of women in Nigeria, 59% in Togo, 35% in South Africa, 27% in Senegal, and 25% in Mali use skin lightening products, and this as far back as 2011.
Yes.
So in some countries, well, just across here, in Nigeria, 77% of women in Nigeria bleach their skin.
yes, yes. I heard that even some women, when they get married, their husbands encourage it. Like they push them into it because it's become so normalized. You know, and it's
How else would he show that he's taking good care of you?
Oh, right.
If you are not looking light and shiny.
Exactly.
Right. Right. So let me read on. Sure. Here it says skin bleaching is a $10 billion business.
Yes.
That number is growing exponentially every year. Ghana's population is approximately 35 million. There are 26 dermatologists.
Yes.
Australia's population is approximately 25 million. They have 500 dermatologists. So that's a whole different conversation.
Yes. I think because Caucasians have recognized the risks of skin cancer, they've done a lot more in terms of medical care. So dermatology is a very important part culturally of their medical care. But for some reason, Africans believe that dermatology is like vanity. It's not a serious medical practice. They think it's just for like microdermabrasion and skin peels. And
listen,
yes,
you're not hungry.
Those things, but
if you're talking to dermatologists, you're probably not hungry.
That's
the rest of us are thinking about food.
The idea is, but our skin is our largest organ, and it's also our most vulnerable. And there's a lot of skin-related diseases that are deadly. So it's really important that we have dermatologists in society that can recognize this. One of the biggest issues now is 80% of Africans that get skin cancer die, because by the time it's diagnosed, they're in a late stage and they can't be saved. If there was more dermatologists, when people went to doctors, they would see early some of those signs and they'd be able to do some level of treatment, maybe to prevent it from getting to a fatality. Right. But because we don't have that kind of treatment commonly, a normal doctor can look at you in stage 4 and see that that's what's going on, because they have a general understanding of cancers. Even though they don't have the specific knowledge, they can see that by the time you're stage 4, that's likely what it is. You'd have lesions and other things that would make it quite apparent. But unfortunately, by that time, it's too late.
Stage 4 sounds like it's pretty dangerous.
It is very dangerous. It's like
stage 4.
It's fatal. By the time you're in that level, there's no hope for you, unfortunately. And that's what happens to 80% of Africans who get skin cancer. It's just very late in the diagnosis. And so, yeah.
Let's come back to you, Delasi, and let's talk about your inspiration for this campaign. Why is this campaign so important to you? I mean, you've been awesome with it consistently, at least from when I knew in 2019 till now. Very consistently going to school, speaking at conferences, speaking at what's the story here?
Well, okay, I started this initiative in 2016, so it's been about 7 years now. And I'm actually working on building an NGO, which the paperwork is in process, so hopefully by the end of June I'll be official. But I think there's two really big influences for me in terms of starting this, and one is colorism. Being a recording artist and being someone who works in entertainment, it's something that I've come into contact with quite a bit. And also, if you notice, especially from the United States, if you look at our biggest pop artists, they tend to be, like Beyonce, Rihanna, Ashanti, those girls, they kind of fit a very narrow idea of black beauty.
Every single one of them, since you said it. I'm thinking names in my head, and every single one of them.
Yes.
It's actually pretty light.
Yes, they tend to fit that type. And that's because in the business we're in, the powers that be believe that in order for you to be successful and marketable as an artist, people have to want to be you. They have to want to look like you, and men have to want you. And they believe that it's a certain kind of look that garners that attention. I don't agree with this, because everyone's different. Beauty is diverse, and it should be celebrated in that way. And I also think that, not everybody has the same tastes. So why would we assume that everybody, wants to look like Beyonce or Rihanna? Not everybody does, And I think diversity is beautiful, and we need to reflect that in the art world so much more than we do. Because representation is important. Young girls look at this and they don't feel represented.
Goodness.
Yes, they don't. And as an artist, when I perform, especially at schools and things, young girls always come to me and say, oh, we need, artists like you. Please don't give up. You have to blow up, because we need girls that look like us to be in those positions, so we know that we can get there. And I remember Lupita Nyong'o, after she won her Oscar, she said something to the effect of, now I know my dreams are valid, and your dreams are valid too. Yes. And even though that was such a powerful statement, it's sad that she thought, because of her skin color, that dreaming of being, a Hollywood actress was something audacious or impossible or silly, because it didn't have validation. And it took her getting the highest recognition in that industry to finally feel like, okay, I'm validated. My dreams are real, you know? And not everybody has that experience. Some people just dream and they get to just dream freely. You know, it's not fair that some of us don't get that freedom and don't get to feel like it's possible and feel like it's tangible. And it's that lack of representation that leads to this.
Wow.
I'll tell you a really quick story that I've never told anyone before. So it's an exclusive on the couch, guys. Exclusive.
Listen.
So I attended the United Nations International School from grade 2 through 12. So my whole childhood and the way that I grew up was very diverse. My best friends were from Lesotho, Tunisia, Ukraine, and the Philippines, respectively. So I just always had a diverse group of people around me, and I always recognized the beauty of diversity. This is why I don't understand this world that we live in, and why this world can't be like that little bubble that I grew up in, you know? I remember one particular afternoon, I was with my Filipino friend and my Tunisian friend, and we were hanging out, and my Filipino's boyfriend came. Now, I didn't like him. He was a black guy. He was, you know, mistreated her, you know, wasn't faithful, like just doing all the silly things that teenage guys do. So I wasn't a fan of his. And I remember this one particular day, he said, you know, Delasi, can I talk to you for a minute? Can I, you know, over there, like in privacy? And I'm like, why does he want to talk to me privately? Because he knows I can't stand him. Like, I don't even acknowledge him. I cannot stand that guy. And I'm like, well, maybe he's planning a surprise birthday party for my friend, and he wants to, you know, fill me in. That's the only thing I could think that would make sense. So he pulls me aside, you know, when we're far enough away from the group, and he says, in my personal opinion, I think you're the most beautiful of your friends. And I'm like, okay. And he was like, but you'll also be constantly overlooked all of your life because you're the darkest of your friends. And I'm like, I mean, I'm just looking at him blankly, like, are you finished? Like, why did you feel the need to tell me that? And I think throughout life, I've had those kinds of experiences where people feel like, how dare you be so confident? How dare you be so proud of who you are? Let me, like, knock you down a few pegs.
Let me tell you something about yourself.
Right. You know, you have a lot of audacity to be moving in your skin the way that you do. You shouldn't be, you know, this happy to look like you do. It's like, I rub people the wrong way because I'm confident. And that really opened my eyes at 16 years old to hear that from somebody and to see that he had to knock me down. You know, he felt like the need to knock me down and tell me the world is not going to accept you. You know, no matter how pretty you are, how pretty you think you are, you know, the world is never going to accept you. So that was the first incident that I dealt with, like, direct colorism. And then there was a few more incidences throughout my work in the industry. But what made me start this in particular was my late uncle Kofi Asamoah had a lunch. And while we were all at his home, he pulled me aside and he said, you know, your mom and dad tell me you do music. I'm very proud of you. If you need anything, please let me know. And I was like, well, there's something I need. You're one of the most prolific, you know, philanthropists, humanitarian leaders the world has seen, honestly. And I can only dream to do just a small pinch of what you've done in this world, but I want to do something. I want to do more than just sing and dance. I want to make some level of a difference, and I don't know where to begin. You know, people are hungry, people don't have education, people are being enslaved, you know, there's human trafficking, there's so many problems, the environment, the animals, like, I don't know where to begin. And he said, okay, well, go home and think about what frustrates you, and then use that energy to work towards a solution. So I did just that. And the first thing I thought about was colorism. That frustrates me every day in this business. Like, what can I do about this? So I started looking things up about colorism, and that's what led me to bleaching and then skin cancer. So that's where I kind of started my initiative. Started speaking at schools, and then moved on to conferences and summits and, you know, things of that nature. So just trying to reach people and educate them about the risks that they're taking when they...
Listen, I'm still stuck on the story that you just told. I'm still there. I haven't moved from
right?
there. I'm still
Isn't
there.
it crazy?
And it's bothering me that it's a black guy who felt the need to pull a black girl aside and remind her that, hey, listen, I see you. You think you are like everybody else. Yeah. With these people, you just seem to think that, listen, let me tell you something. And so it's us, right? It's us. And I appreciate that you appreciate that we are a product of our history and our present.
Oh, yes.
Fact.
Oh, yes.
But what do we do because we need to start from somewhere. How do we start decolonizing our minds
Yes.
to the point where we accept ourselves enough to be enough?
Yeah.
How do we do that, Delassie?
You know, I think it starts at home. You know, I think parents need to have these conversations with their children and prepare them for what they're going to face in the world. Because if you're unprepared, then it leaves you vulnerable and it leaves you open to insecurity. And insecurities are what leads to this bleaching stuff, right? So we really need to, parents need to empower their children and encourage them, you know, just encourage them to be proud of themselves, to take very good care of their skin, because beautiful skin is well taken care of skin. It doesn't matter what the tone is. It's well taken care of skin. You know, it's pampered skin, it's protected skin. That is what beautiful skin is. It's not a shade, because all shades are beautiful, right? It's the health of your skin and how you treat your skin and protect it that makes it beautiful. And I think these are things that we need to speak on at very young ages so that children understand, because that's what my parents did with my sisters. You know, they encouraged us from such a small age and let us know that we were beautiful and we had lovely skin. I remember my mom always used to say, I envy your skin so much. I wish I had a skin tone like yours, because she's significantly lighter than I am. And you know, being 4 and 5 years old, you idolize your mother. That's the first woman that you idolize in life. So to hear that your mother, your idol, envies you is powerful. And so she did these things on purpose to give us that confidence. And more parents need to take on that role, like proactive, and talk about these things.
Right. And there's so much more we can do with very silly phrases like me brony and, you know, all those. There's so much to do.
So much to do.
Just like there's so much more to talk about, and yet we don't have time.
No, you have to bring me back.
You have to come back.
I have to come back.
When?
As soon as possible. Let me know.
Absolutely.
I'll be
Because
around.
this is a conversation that needs serious unpacking. This conversation about being enough, being comfortable in your skin, you know, accepting yourself. I think it's where it starts from. Accepting yourself.
Amen.
So you can present yourself the way you are. And then the rest of the world will just have to accept you. Now look, everybody's here to suck us. But before you go, how can we help with this thing this wonderful thing that you're doing? How can we assist you? And what do you want us to leave this conversation with?
Yes, well, you know, you can assist me in quite a few ways. I do have an official website, delassie.com. So if anybody's interested in joining me in the work that I'm doing, if you'd like to volunteer, if you'd like to offer funding, I'm taking donations for my NGO, just, you know, find me on delassie.com and just, you know, hit the email button.
Let's spell it, Delassie. Let's spell it.
Dellassie. Delassie.
Right. Everywhere on social media.
Everywhere on social media.
Right,
yes.
Right.
And I think what message I would like to leave is something that I've echoed kind of throughout this interview, but it really starts from within. To love yourself and have confidence and believe in who you are makes your dreams valid, makes your wants, needs, and desires valid. You don't need validation from anybody else but you inside. And work through that and from there, and you will get to where you want to be in life and do everything you want to do in life.
Absolutely. Absolutely. You're always a delight. You're always a pleasure. I just love to see you. Thank you.
Thank you.
Thank you. Thank you for watching the show. Please do follow Delassie everywhere. Facebook,
everywhere.
Instagram, you know, Twitter, LinkedIn, everywhere. Let's support what she does. But let's take this message that she said. This is such an important message that you are enough. Accept yourself. Be, you know, and let's do better. Let's do better with our skin. This is all we have. This is all that we have. Thank you for watching today's show. I will see you tomorrow. Tomorrow too, I will be here. I will see you tomorrow. Make a date with me at 7:30. Have a lovely evening. Month is still here. We have one more day to go in month. Enjoy it, and I will see you tomorrow. Bye. Thank you.